Urinary incontinence, neurogenic bladder, or reflex incontinence. Neurogenic bladder is a dysfunction of the lower urinary tract that comes as a result of a condition or disorder of the nervous system. It can be a disease or condition of the central nervous system, such as a stroke, spinal cord injury, traumatic brain injury, or multiple sclerosis, or those with congenital anomalies, such as spina bifida, particularly myelomeningocele, anorectal malformations, such as imperforate anus, as well as those with metabolic or infectious diseases that affect the nervous system, such as diabetes. One way to classify neurogenic bladder is by naming it as upper motor neuron lesion versus lower motor neuron lesion. An upper motor neuron lesion is any lesion above the sacral cord. The overactive bladder contracts without voluntary control, and the individual cannot tell or feel when the contraction is taking place. This type of problem occurs with spinal cord injury above the sacral area. Spinal injuries at the sacral level result in a bladder that does not contract. Think back to the earlier discussions on how a baby's bladder works. As the bladder fills with urine, a message is sent to the spinal column, which sends an immediate impulse back to the bladder to contract. This is known as the micturition reflex. In those with sacral cord lesions, the stimulus sent to the bladder is shut down. The spinal cord is unable to send a message back to the bladder to contract. This results in an acontractile or areflexic bladder. As a result, the bladder continues to fill without emptying, and these individuals will experience urinary retention. In the urodynamic-based system established by Wine, neurogenic bladder problems are classified as seen on this slide. This includes failure to store urine because of the bladder, failure to store urine because of the outlet from the bladder, failure to empty because of the bladder, or failure to empty because of the outlet from the bladder. Let's talk about this in more detail. Failure to store urine because of the bladder is caused by detrusor overactivity in those with a neurologic disorder or injury. Examples would include those in the early aftermath of a stroke in which the detrusor motor area of the brain is injured, multiple sclerosis, or cervical below C2. Also thoracic level spinal cord lesions and Parkinson's disease. For individuals with sensation, typical urge symptoms of frequency, nocturia, and urgency occur. Some individuals will have absent or decreased sensation as the result of the neurologic issue and will have incontinence and no perception of the bladder filling, as well as enuresis. For those with some sensation, the sense of bladder filling may be indicated by atypical sensations such as tingling of the jaw or side of the face. This latter type of neurogenic overactive bladder is the result of paralyzing spinal disorders. For those with stress incontinence and those with neurogenic bladder dysfunction, the damage or trauma occurs in the lumbosacral spine segments and lead to denervation injuries of the external urinary sphincter. This results in greater or lesser degrees of stress incontinence, which is leakage of urine with laughing, coughing, or physical activity. In addition, some individuals, as a result of management methods for incontinence, results in erosion of the external sphincter with an inability to hold urine. For those with neurogenic bladder, a third subtype is that of failure to empty because of the bladder. An underactive detrusor is defined as a detrusor contraction that has inadequate strength or duration to empty urine from the bladder in a reasonable period of time. The individual complains of difficulty in initiating the urinary system, a weak urinary stream with dribbling either at the end of the stream or post-void dribbling, and a feeling of not completely emptying the bladder. The post-void residuals are high, and this is not the only condition with which this weak detrusor activity is found. Individuals who are constipated or are on antimuscarinics, which are used for neurogenic detrusor overactivity, may also contribute to this problem. Uroflowmetry and voiding pressure flows can help identify this problem. As mentioned before, emptying of the bladder occurs as a result of a complex coordination between the brain, spinal column, bladder, and sphincters. Normally, the bladder wall needs to be able to slowly distend as it fills in order to keep the bladder pressures low. When the bladder contracts, the sphincter is able to be relaxed. In the case of detrusor sphincter dysinertia, when the bladder contracts, the sphincter contracts. This incoordination of the bladder and sphincter results from a lesion between the sacral cord and the pons or brainstem from C2 to S1. Individuals may have bladder neck dysinertia in which the smooth muscle of the bladder neck or internal sphincter mechanism fails to relax during a detrusor contraction, resulting in bladder outlet obstruction. This is a result of complete spinal injury above the S2 and incomplete spinal cord injuries, usually T9 and lower. Benign prostatic hypertrophy may be a contributing cause to both of these problems in men. Bladder management programs must take into account both urethral opening and bladder wall compliance capability in order to mitigate the effects of the hostile bladder. Upper urinary tract distress is impaired function of the upper urinary tract associated with neurogenic bladder. As you know, the upper urinary tract consists of the two kidneys, renal pelvis, and ureters. Clinically, the individual has febrile urinary tract infection, or chronic or recurring pyelonephritis, as well as vesicoureteral reflex, ureterohydronephrosis, and impaired renal function. In those with neurogenic bladder problems, low bladder wall compliance and increased urethral resistance increase the likelihood of upper urinary tract distress. This problem is seen in those with bladder sphincter dysinertia. As the bladder contracts, so do the sphincters, forcing urine back up the ureters, which can cause upper urinary tract damage. In addition to filling and overdistension of the bladder, autonomic dysreflexia may also be a result of overfilling of the rectum or from an infected pressure ulcer. In autonomic dysreflexia, patients will experience hypertension, sweating, and erythema, most likely in the upper extremities, and may suffer from headaches and blurred vision. Ways to eliminate bladder outlet obstruction caused by the underlying bladder sphincter dysinertia include checking that catheters are not twisted or kinked, and in men, sphincterotomy, which is a surgical destruction of the sphincter mechanism resulting in total urine leakage. Or there can be a placement of a urethral stent, which is a thin tube into the bladder that allows for continuous drainage. In these last two methods, a man would then need to wear a condom catheter continuously. These two procedures used to be commonly done, but have declined dramatically secondary to long-term outcomes that are less than optimal. Ways to decrease the highly elevated blood pressure include having the person sit upright. Drug treatment includes use of rapidly acting vasodilators, including sublingual nitrates or oral clonidine. Ganglionic blockers are also used to control sympathetic nervous system outflow, such as terazosin. Topical nitro-paste is a convenient and safe treatment. An inch or two can be applied to the chest wall and wiped off when the blood pressures begin to normalize. If a quick response is needed, one can also give 10 milligrams of nifedipine sublingually. It is imperative to assess the cognitive abilities, physical dexterity, and mobility status of the patient. This information allows the clinician to better determine an appropriate, individualized plan of care. Clean intermittent catheterization is often sometimes used to manage individuals with neurogenic bladder from reflex incontinence, so the ability of the individual to be able to follow complicated instructions, maneuver and manipulate equipment is important for the clinician to know. If the person is unable to perform this for him or herself, availability of a willing caregiver is also important to know, so the individual could be taught. Be aware of how quickly to expect progression of individuals' underlying neurologic condition in order to determine if the right amount of time and energy spent on learning and mastering a management method is worthwhile. The type of management program the person is currently using and the problems encountered or concerns the individual has with the current plan need to be discussed. The healthcare clinician wants to ask specific questions in order to obtain a clear and detailed understanding of the current management plan and potential problem areas. Urinalysis results of leukocytes and nitrates should not be cause for further investigation in an individual using clean intermittent catheterization or an indwelling catheter, as these substances are often present. Further investigation is warranted if clinical signs of a urinary tract infection are present or suspected. Urodynamic testing is commonly indicated for individuals with neurogenic bladder dysfunction in order to determine detrusor contractility, bladder wall compliance, and evidence of bladder sphincter dysinertia. Further information on assessment is included in the assessment lesson. There is no definitive evidence that management of fluid and diet, as well as maintenance of regular bowel function, is clinically helpful for those with neurogenic bladder problems, but inclusion in teaching is considered to be an important part of the management plan. The type of treatment plan considered is based on the patient's presenting symptoms and abilities. Spontaneous voiding is occasionally feasible as it requires the individual to have some mobility and preservation of bladder sensation so they may be able to void. There is a high risk of urinary incontinence, but this method best preserves the upper urinary tract. Use of a containment product and skincare is very important if this type of management is chosen. Reflex voiding is a type of voiding in which a man triggers voiding through gently pulling on pubic hair, stroking the inner thigh, and similar type strategies in order to cause a reflex contraction of the bladder with resultant passage of urine through the urethra. The individual voids into some type of external collection system, usually a condom catheter. This method may be used in persons with injuries above the T12 area that leave the sacral segment intact, thereby having the reflex arc left intact. Care must be taken as the bladder must be able to overcome any sphincter resistance. Injury to upper tracts can occur if there is sufficient internal impediment to voiding. In order to help prevent this problem, individuals may take alpha-blocking agents, have Anabutymoline toxin A injected into the rhabdosphincter, or have sphincterotomy performed. The individual can also have increased episodes of UTI and skin complications. Urethral stents are thin, flexible tubes placed into the bladder through the urethra and allow for continuous drainage of the bladder in men. Sphincterotomy in males is the therapeutic destruction of the closure mechanism of the striated urethral sphincter function and sometimes proximal sphincter as well. This is usually done through endoscopic means. The purpose is to overcome functional obstruction caused by significant detrusor sphincter dysinertia or to reduce outlet resistance. Both of these interventions require the man to use a condom catheter to keep dry. Clean intermittent catheterization requires dexterity of upper extremities and a willingness to perform the procedure. It is a procedure that is often used for those having neurogenic bladder. For those with neurogenic detrusor overactivity, it may be necessary to include the use of antimuscarinics, beta-3 agonist, anabutylamine toxin A, or alpha-adrenergic agonists to decrease bladder contractions or relax the sphincters. Indwelling catheters may need to be used for those who are unable to adequately manage the neurogenic bladder in any other manner, or for the paraplegic or quadriplegic woman who is unable or unwilling to adequately perform clean intermittent catheterization. As was discussed in the retention lesson, the use of indwelling catheterization should not be made lightly. There is an increased risk of upper urinary tract distress after 10 to 15 years, increased renal deterioration, and risk of bladder cancer from long-term use. Meticulous management and routine follow-up are required. Surgical options include augmentation cystoplasty as well as formation of a continent catheterizable stoma. In augmentation cystoplasty, a bowel segment, generally a piece of ileum, is removed from the fecal stream and the bowel is reanastomosed. The isolated segment of bowel is opened on its anti-mesenteric side, thus preserving its nerve and blood supply while at the same time interfering with the peristalsis. This segment is then patched into the bladder, increasing bladder capacity, improving bladder wall compliance, and alleviating neurogenic bladder overactivity. Patients almost always use clean intermittent catheterization to empty bladder after this surgery and should be taught to measures to control mucus production, including adequate fluid intake and irrigation of the bladder if needed. The possibility of cancer developing in the augmented bladder long-term needs to be discussed with the patient prior to surgery, and routine follow-up is required. The continent catheterizable stoma is used for those who have discomfort from or trouble performing clean intermittent catheterization. A piece of bowel or appendix is anastomosed to the bladder, forming a catheterizable stoma. The stoma is often placed into the umbilicus. The individual can then catheterize the bladder through this bowel segment without enduring incontinent episodes. Other surgical procedures that may be performed include sacral neuromodulation, suburethral slings, and artificial urinary sphincter and transurethral sphincterotomy. Each of these procedures has been discussed in more depth in other areas of the course. In some rare cases, an incontinent stoma may also be created, such as an ileoconduit. All individuals with neurogenic bladder are encouraged to follow up with members of the health team, at least annually. Condom catheters will be discussed, as some men with neurogenic bladders use this as part of the treatment plan. Condom catheters are, as the name suggests, a condom with a connection part at the end that can be attached to a leg bag or bedside gravity drainage bag. This device is suitable for men with moderate to heavy loss of urine and men with limited mobility who experience frequency and urgency, and can be used in combination with intermittent catheterization. They are contraindicated for those who have cognitive impairment and will not be able to follow or understand directions for use, or for those who may be psychologically vulnerable, and individuals who have decreased genital sensation, as they may not be able to tell if a problem is occurring as a result of the device. These devices need to be carefully fitted and applied to prevent injury and to the shaft of the penis. While there are many styles, sizes, and adhesive options, they are all single-use and require some type of adhesive device to prevent the condom part from slipping off. Options include latex and synthetic. Latex versions are less costly, but can be an allergen for some men. Synthetic or silicone versions are available for those at risk from the latex versions. Some are coated internally with the adhesive, and some simply roll into place. If using this option, be sure to inspect the skin after the first 24 hours and periodically thereafter for signs of skin irritation. There are also reusable styles of condom catheters. The sheath is placed onto the penis and held in place by a Velcro strap or a ring that is placed over the condom catheter, which is then inflated to hold it in place. It is imperative that cognitive and sensory assessment be done to check that the man is alert enough to follow instructions for use and has no sensory impairment that would prevent him from being able to be aware of discomfort that could indicate a problem. Condom catheters should have a molded tip in order to prevent twisting and kinking. It is imperative that the catheter be sized appropriately Each manufacturer has a size guide that should be used in order to obtain the correctly sized catheter. Some come in large, geriatric, pediatric, and standard sizes. Long pubic hair should be clipped in order to prevent the hair from being caught in the adhesive, and shaving can cause skin irritation. Use of a skin sealant, also called a liquid barrier film, can be used under the condom in order to provide the skin with some protection. It is important to allow the liquid barrier film to dry thoroughly prior to applying the sheath. The penile skin should have any barrier or residue removed prior to application of a new condom catheter. The skin should be cleansed and dried thoroughly. There should be a gap between the tip of the penis and the catheter in order to prevent trauma to the penile head, but not so wide that twisting and kinking of the tip of the condom catheter would occur. Leaving the foreskin down prevents phimosis. Some catheters provide a hair guard. If not, one can use a paper towel with a hole cut in the center and use during the application of the catheter with removal once the sheath is in place. This prevents the inadvertent trapping of pubic hair. Soaking the penis with a warm washcloth for 30 seconds can help in sheath removal. Initially, the catheter should be removed every day, unless an extended wear sheath is being used. Be sure to check manufacturer guidelines for recommended wear time. Men with short penises may find a non-sheath male external continence device helpful. One available has a hydrocolloid adhesive area that adheres directly to the glands rather than the shaft of the penis. This may also prove effective for men who are physically active. One needs to follow manufacturing guidelines for specific fitting and application points, then evaluate for effectiveness or any potential problems. On this slide, you see delineated times when an individual should be referred for further workup. Signs and symptoms of urinary tract infection, hematuria, and complex systems, or those that do not match physical findings, are all reasons to refer a patient for further workup. Those who do not respond to behavioral methods after an adequate trial should also be referred. Collaboration with colleagues is key in obtaining optimal patient results. This ends our lesson on neurogenic bladder. Thank you for your attention.